Biochemical data is listed below, but keep in mind your non-weight-bearing children need to be monitored for bone density, and those that are on medications, there could be vitamin and medication interaction. Those children with upcoming surgery, you want to check their pre-albumin. For the dietary assessment, food records can be very helpful, not only for assessing caloric, nutrient, and fluid intake, but for assessing eating patterns, frequency and duration of meals. We often find that parents are spending all day feeding their children. It also can tell us what types of textures they're tolerating or avoiding, and whether the child is being fed in a parent's arms, a high chair in front of the television, or running around. Feeding skill development. Observing a mealtime is very important. In New Hampshire, we are able to do home visits, school visits, daycare visits, and other places where the child may be taken care of. Observing a child at mealtime provides information on feeding skills, the utensils being used, whether the child is fussy through a meal, or grimacing or arching back, refusing to drink, coughing or choking. I do have a few children who the parents will tell me they fall asleep after a few bites. And after doing a swallow study on these children, we saw that the child was aspirating on liquids and solids, and the only way they could tell us this, because they could not communicate, was to fall asleep after the first few bites of food. For the children that are nonverbal, it is very important to look at their movements and gestures during meal times. See a child taking a long time to eat or showing any distress, we are able to refer to our feeding and swallowing specialists, as we have a feeding team here in New Hampshire. I always ask parents, do you enjoy mealtime, which can give us a lot of insight as to just the mealtime and the interactions between family and child. Other factors to consider are the parent-child interaction, reinforcement patterns, environmental influences. These factors, I think, we have already discussed in the previous slides, but just keep in mind they can help give you a lot of dietary information. And then this last slide, we just wanted to show you what the assessment form is that we use in New Hampshire. I am now going to turn this over to Gail Lansing, who will be discussing nutritional challenges.
Children with special health care needs present dietitians with a variety of nutrition challenges. During the next section of this conference, we will discuss strategies to calculate and meet calorie, protein, fluid, and vitamin mineral requirements. Many of the children have low-calorie needs, and it can be challenging to meet their requirements for other nutrients within the context of a low-calorie diet. We will also briefly review medications that may affect nutritional status. Fluid requirements may be calculated based on body weight using the Holiday-Seeger method. It is essential that children with special health care needs meet their minimal fluid requirement. As they are often unable to verbalize thirst, they may have additional fluid loss due to drooling, and adequate fluids can help alleviate constipation. One of the things I found most remarkable from a dietitian's standpoint when I started working with children with special health care needs was their wide range of calorie needs. Typically, but not always, calorie requirements are lower than what would be expected for same-age peers. Standard equations can overestimate calorie needs. If a child has had a central nervous system impairment since birth, their growth is typically compromised throughout life. However, if a child has a brain injury later on, he or she will often follow growth patterns expected for same-age peers. The energy balance method, which involves titrating calories up or down depending on weight goal, is often used to estimate calorie needs. A study done with the residents at the Seven Hills Foundation in Groton, Massachusetts, a pediatric long-term care facility, involved measuring the resting metabolic rate of 12 residents and comparing the resting metabolic rate to that calculated using standardized equations. It was concluded that the standard equations overestimated needs. Length was found to be a better predictor of energy needs than weight. Average calorie needs for residents in the study were between 63 and 75% of needs predicted using standardized equations. There are guidelines available for determining calorie needs for children with Down syndrome and spina bifida. These guidelines are based on height, as height is a better predictor of calorie needs than weight. Dietary reference intakes established for age are used as a goal to estimate vitamin and mineral needs. upper tolerable levels are used as a guide for maximum intakes. Since many of the children are on hypocaloric feeds, it is important to check for adequate intake of protein, vitamin, mineral, fluid, and fiber. Megadosing for children with Down syndrome and autism is still controversial. If zinc, iron, magnesium, iodide, vitamin K, or vitamin D need to be supplemented, needs can often be met with one crushed children's multivitamin with minerals daily. About 50 milligrams of phosphorus is found in most children's vitamin and mineral tablets. If this does not boost phosphorus to requirement, then NutriFos powder, which contains 250 milligrams per packet, may also be used. It is essential that sodium needs be met, as hyponatremia can increase the risk of brain damage. Adequate sodium intakes are based on the child's age. If a child is on a hypocaloric feeding and the feeding does not contain the minimum requirement for sodium, then table salt, which contains 2,300 milligrams of sodium per teaspoon, or light salt, which contains 1,100 milligrams of sodium and 1,500 milligrams of potassium per teaspoon, may be used. It is essential to meet calcium and vitamin D requirements to promote bone health. The calcium goal for the children at Seven Hills is set at between 100 and 150% of the dietary reference intake. This is because children with special health care needs commonly carry several risk factors for osteopenia due to non-ambulatory status, hypocaloric diets, which may lack adequate calcium and vitamin D, lack of sunlight exposure, especially in children that are spending a lot of their life in hospitals or long-term care facilities, and use of medications which may interfere with calcium absorption or bone health. Meeting calcium needs can be accomplished through the use of a crushed multivitamin with minerals, neocalglucon, which contains 115 milligrams of calcium per teaspoon, and or crushed Tums, which contains 200 milligrams of calcium per tablet. Now Trish is going to discuss medications that may affect nutritional status.
Antibiotics can often cause diarrhea and wipe out the good as well as the bad bacteria. Pre- and probiotics can be beneficial to restore intestinal flora. Monitoring vitamin D, calcium, and B vitamins when children are on long-term anticonvulsants is important, and if a child is tube-fed and on Dilantin, there should be separation of 2 hours between the tube feeding and administration of Dilantin. Cardiac medications affect minerals such as potassium, magnesium, calcium, and folate. Fluid balance also needs to be monitored closely for those children who are on diuretics. It is often helpful to try timing meals so that they are given apart from medication administration to try minimizing the side effects noted. Offering foods which are high in nutrients is also crucial for most children with cardiac defects, as growth is often a concern. Children with ADHD may be on a stimulant therapy, and this can significantly impact their appetites in a negative way. Some children won't eat at all during the day if they're on a sustained release medication that lasts 12 to 14 hours. It is important to focus on nutrient-dense foods before and after the medication takes effect, and try to promote small, frequent meals throughout the day. Children on tranquilizers are susceptible to excessive weight gain, and monitoring intake and encouraging exercises are recommended. Those children who have been on long-term steroids, we see this a lot in preemies with BPD, or children with cystic fibrosis, are at risk for porous bones, diabetes, and obesity, as steroids often increase appetite. GI medications used to control reflux and constipation may have side effects which include anorexia and diarrhea. It's important to synchronize the timing of GI medications correctly, and often smaller frequent feedings can help with tolerance. Optimizing the child's nutritional needs specific to the GI issues that are apparent can also help to decrease the need for medication. For example, a high-fiber, fluid-rich diet may help decrease the medication requirements for a child with constipation. Now I'm going to introduce Sharon Weston, who will be discussing GI-related issues.